Hello everyone and welcome to my YouTube channel. This is Dr. Naz and today I'll be discussing about pneumonia. So pneumonia is defined as an infection of the lung parenchyma and it has following main types: community acquired pneumonia, hospital acquired pneumonia, ventilator associated pneumonia, and aspiration pneumonia. In aspiration pneumonia, there will be the organisms which are present in the gut, and when they will go into the lung, they will cause the infection. So community acquired pneumonia refers to pneumonia occurring in the community or within the first 72 hours of hospitalization. These are of two types: typical community acquired pneumonia and atypical. The typical pneumonia is caused by the organism Streptococcus pneumoniae, which is the most common cause. Other are Haemophilus influenza, Staph aureus, and aerobic gram-negative rods, example Klebsiella and Enterobacteriaceae. So community acquired pneumonia, the typical one, usually presents with sudden onset productive cough, usually purulent sputum, dyspnea and pleuritic chest pain, fever, rigors and chills. There will be tachycardia, tachypnea, bronchial breath sounds, dull percussion note, and increased vocal phreatus. On chest X-ray, there will be consolidation. This chest X-ray is showing consolidation of upper lobe of right lung, which is a characteristic of typical pneumonia. So the atypical community acquired pneumonia is caused by the organism that are not visible on gram stain and they are not culturable on standard blood agar. Example Legionella, Haemophilia, Mycoplasma pneumoniae, Chlamydia, Pneumocystic carni, and viral infections. Atypical community acquired pneumonia presents with gradual onset of the symptoms including dry non-producing cough, headache, myalgias, etc. Some GI symptoms are also present. Chest X-ray will show bilateral interstitial infiltrates and there will be no consolidation. This is a picture of atypical pneumonia which is showing bilateral chest infiltrates and there is no particular consolidation seen in the X-ray. These are the organisms and the features of the organism. Example is Streptococcus pneumoniae, which is the most common cause of typical pneumonia, and it is gram-positive lancet-shaped diplococci with rusty colored sputum. It is important point. Most common cause of community-acquired pneumonia. Drug of choice for this is penicillin G and amoxicillin. Staph aureus is gram-positive cocci and it will have yellow sputum. Most common cause of pneumonia after influenza infection. It is associated with IV drug abuse and it causes bilateral cavitatory bronchopneumonia. The drug of choice for methicillin sensitive Staph aureus is flucloxacillin. However, for methicillin resistant, vancomycin is the drug of choice. Haemophilus influenza is a gram-negative rod and it is associated with COPD and smokers. It most common bacterial cause of acute exacerbation of COPD. Klebsiella pneumoniae is gram-negative rod and its association is with elderly patients in nursing homes. So, and alcoholics and diabetics. It will have currant jelly sputum and which is blood tinged thick mucoid sputum and the drug of choice is ceftriaxone. This is Legionella pneumoniae, which is associated in water coolers, air conditioners and ventilating systems. The risk factors include alcoholics, immunocompromised individuals, example those patients with organ transplant, pneumonia with gastrointestinal symptoms like abdominal pain, diarrhea. CNS symptoms may also occur, example headache and confusion, hyponatremia, deranged liver function test, because it is the cause of atypical pneumonia. So there will be different symptoms and lung symptoms can also be present, example dry cough, but the other symptoms are predominant, so you may confuse with the picture of pneumonia. Mycoplasma pneumoniae, it's also the cause of atypical pneumonia. Bacteria with no cell wall, so there is no visibility on gram staining. It will cause atypical pneumonia and erythema multiforme is also caused by mycoplasma. The complications may include Stevens-Johnson syndrome and Guillain-Barré syndrome. Pseudomonas aeruginosa is gram-negative rod and it is the most common cause of nosocomial pneumonia. Most common cause of death due to pneumonia in patients with cystic fibrosis. So for the diagnosis of community acquired pneumonia, we can perform chest x-ray, which will either show consolidation in case of typical pneumonia or bilateral chest infiltrates in case of atypical pneumonia. Blood test can also be performed, which include complete blood count, which may show leukocytosis. Urea creatinine electrolyte can also be done, blood culture can also be done, and liver function test, C-reactive protein, arterial blood gases, sputum culture. And if there is difficulty in obtaining sputum, then bronchoalveolar lavage can be done to obtain sputum, and if the patient is immunocompromised and if the patient is in ICU. The complication of pneumonia includes parapneumonic effusion, abscess formation, empyema, that is pus in the pleural cavity, deep venous thrombosis and pulmonary embolism, bacteremia dissemination, which is sepsis. So before starting treatment for pneumonia, it is important to calculate KERP 65 score, which includes confusion, blood urea nitrogen of more than 7 millimole per liter, respiratory rate of more than or equal to 30 breaths per minute, systolic blood pressure less than 90 millimeter of mercury, and diastolic blood pressure of less than 60 millimeter of mercury, age of more than or equal to 65 years, and all these symptoms get 1 point each. A score of 0 to 1 can be managed on outpatient basis. A score of 2 is criteria for inpatient management, and a score of 3 or more means severe pneumonia and we should go for ICU admission. Other markers of severity include if there is more than one lobe involvement on chest x-ray, if partial pressure of oxygen is less than 60 millimeter of mercury, if there is low albumin, that is less than 35 gram per liter, if WBC, that is white blood cell count, is less than 4,000 or more than 20,000, and if blood culture is positive. So these all are the markers of severity. The most important aspect of treatment is to decide whether to hospitalize the patient or treat as an outpatient. This decision is made not only on the basis of severity scores, but clinical judgment is also critical. The treatment duration for community acquired pneumonia is 5 to 7 days, and do not stop treatment until clinical improvement or if patient is afebrile for 48 to 72 hours. Hospital acquired pneumonia need treatment for 8 days and 15 days of infection with Pseudomonas and other non-fermenting gram-negative rot. So for outpatient treatment, there are two options. Option 1 include treatment with macrolides or doxycycline, and it is suitable for patients who are less than 60 years of age or they are previously healthy and they have not taken any antibiotic in the past 3 months. Option 2 include treatment with respiratory fluoroquinolones like levofloxacin and moxifloxacin, or macrolide plus second or third generation cephalosporin, or macrolide with amoxicillin and clavulanic acid. So this option is suitable for patients who are more than 60 years of age and those who have comorbidities, and for those who have taken antibiotics in the past 3 months. So for inpatient management, you can either give respiratory fluoroquinolones or you can give ceftriaxone plus azithromycin. Hospital acquired pneumonia is also known as nosocomial pneumonia, and it is defined as pneumonia occurring after 72 hours of hospital admission, and these patients have a higher incidence of gram-negative bacilli, example E. coli and Pseudomonas. Therefore, macrolides are not effective empiric therapy in these patients. The treatment will include any one of the following: either anti-pseudomonal penicillin, example piperacillin or tazobactam, anti-pseudomonal cephalosporin, example ceftazidime or cefepime, or carbapenems like imipenem and meropenem. Ventilator associated pneumonia refers to pneumonia in patients on mechanical ventilation. Patients on mechanical ventilation are at increased risk for developing pneumonia because there is impaired mucociliary clearance of the respiratory tract because they cannot cough, and there is positive pressure which impairs the ability to clear colonization. So the patient with ventilator associated pneumonia will have fever, rising white blood cell count, new infiltrates on the chest x-ray, purine secretion from endotracheal tube. So the investigation we will do for it are tracheal aspirate, bronchoalveolar lavage, video assisted thoracoscopy, which is most accurate, and open lung biopsy, which is rarely done. For ventilator associated pneumonia, the formula of treatment is you have to select any one of the anti-pseudomonal plus one of the antibiotics, example fluoroquinolones, plus you have to give any methicillin resistant anti-staphylococcal agent. So what are anti-pseudomonal drugs? Either anti-pseudomonal penicillin, example piperacillin or tazobactam, or anti-pseudomonal cephalosporin, either ceftazidime or cefepime, or carbapenems, example imipenem and meropenem, plus combined with respiratory fluoroquinolone, either levofloxacin or moxifloxacin, or you can give gentamicin plus azithromycin. Plus you have to give a MRSA agent, example vancomycin or linezolid. That's it for today. I hope you learned something from my video. If you do, please like it, share it, and subscribe to my YouTube channel. And thank you so much for watching.